center, where most of the center in European, they have a dedicated heart failure clinic. So before I joined the HUKM center here, I was working in the heart failure clinic under the supervision of University College Dublin regarding just managing the heart failure, even up to the level that we can give less six in the clinic and monitor for a few hours. If the patient improve, we can discharge the patient and then bring back in a couple of days time with monitoring of the functional status and whether patient can be admitted or not. So there are very nice service available most of the European countries. And we also know that in the Southeast Asia, about 9 million of people has heart failure with prevalence of heart failure about 6.7% in Malaysia and about 4.5% in Singapore. But we'll know better when we completed our My Heart Failure registry. So along with the NCVD that we been done by the NHAM, National Heart Association of Malaysia. Now we are establishing our own database regarding the heart failure, and we will know better regarding the prevalence and also what is happening to our heart failure populations. And we know that in the Asian heart failure data, outcomes in Asian patients with both heart failure and reduced or preserved ejection fraction are poor overall and worse in the South Asia country. We can see about 13.6% here in the Southeast Asia combined in the mortality of 1 year. And if it is subdivided into the CV and non-CV deaths also, we are very high. Okay, so almost 75% of the patients with heart failure have the additional contributing factor contributed to their heart failure status. So there are modifiable clinical factors strongly associated and consistently associated with heart failure, including diabetes, hypertension, valve disease, overweight or obesity, and also the MI itself. The LV hypertrophy sometimes is associated with hypertension and also the overweight itself. Okay, so in our center here, we have a quite active bariatric surgery team, where when the patient goes for the surgery, we will do a baseline echo, and almost I can say about 80% of the patient that I reviewed before they can go to the bariatric surgery have some form of the LV hypertrophy, regardless they are hypertensive or not. So, but we don't have a specific data yet, let's say in 3 months' time, where after the bariatric surgery, whether the LV hypertrophy improved or not. But I'm sure there is, and a few case write-up or case studies showed that. Okay. So diabetes is associated with a worse prognosis in patients with heart failure, and we know that CV death or hospitalization of heart failure in patients with or without diabetes based on the ejection fraction itself, and we can see that in the patient of the reduced ejection fraction, of course, they are more sicker and they do worse. And having said that, even in the preserved ejection fraction group, if they are diabetes, they are doing worse compared to the non-diabetic populations. So the pathophysiology mechanism of the diabetes can contribute to the development of heart failure. What does it means by this slide is, in the diabetes itself, as been said by first speaker, they already have the ASCVD, and they sometimes associated with the hypertension. They have outcome of the ischemic heart disease, and most of the patients now survive. I think about 80% of the patient will survive in this heart attack, regardless of any of the heart attack they have. They have chance to survive because of the advancement of the treatment. And then after that, they go into the heart failure patients. Okay, so hypertension itself can cause the hypertensive cardiomyopathy and can be directly involved into the development of the heart failure. and there are some complex mechanisms that happen in the diabetic itself. So they can damage a lot of things, especially especially to the formation of the fibrosis inside the heart itself, and this can cause a diabetic cardiomyopathy and goes to the heart failure. And this this type of patient, sometimes we need the diagnosis of exclusion, meaning that we do serial investigation first, and then we'll see from here, uh, you know, sometimes we need to exclude the ischemic heart disease or hypertensive cardiomyopathy before we can safely say that this is the diabetic cardiomyopathy. So what about the heart failure progression in time? So we know that there are a few risk factors that can cause the heart failure, but when they have established diagnosis and then they go to the hospital, sometimes they have the acute decompensation with the treatment, and then they can go into the worsening heart failure, and they can go into the mortality. So this one has been progressed, whether we do nothing or we do something, they still progress into the mortality. Okay, so when we know that any hospitalization of the heart failure itself can cause the mortality, and every hospitalization can make the prognosis worse, and the hospitalized heart failure, discharge, and chronic heart failure become a conundrum, and sometimes very difficult for us to stop this progression even with the advancement of the treatment that we have. And the Kaplan-Meier plots for the all patients with worsening heart failure, almost 30% of the patient will die within 2 years. Okay, and we know that several studies before for all the treatment that we give to the patient can reduce the mortality, but we know that there is a residual risk in the heart failure with the rejection, reduced ejection fraction remains despite the use of the availability of all the medical treatment that we have. And we see such as that the treatment adding to the beta blocker reduce the mortality. All of this treatment, ACE inhibitor, beta blocker, MRA, and ARNI, they are all the disease modifying medications, and they are reduce mortality, but still the mortality is still concern regarding this management. Regarding the MRA itself, okay, we all exposed to the spironolactone. Okay, there are one agent, eplerenone, there are new agent available, but the pickup of the treatment into the patient due to cost are very limited. The same as ARNI as well. I think maybe 30 to 40% of the patient in heart failure can be on ARNI for some reason. For some reason, they cannot all be on this due to the kidney disease or due to the cost itself. Okay, so as been mentioned in the first speaker itself, the program of the MPAREC outcome, the first to show that the risk reduction in the severe death and also the heart failure, hospitalization of the heart failure. In the MPAR program, we know that the severe death has been reduced, and also the hospitalization of the heart failure also been reduced. So, however, there are only small proportion of the population who has history of the heart failure before. As we know in the EMPA, Canvas, Declare and Vertis program, we can see only about 10 to 14% of the patient who has the heart failure before, but in Vertis there are slightly more. However, we don't know the progression of the heart failure when we do a systematic evaluation of each treatment. Okay, and we know this one has been mentioned before. All the EMPA SGLT2 give benefit to the patient, especially in terms of the hospitalization of the heart failure. All four studies before showed a benefit reduction in terms of the hospitalization of the heart failure. So what is SGLT2 do to the heart failure? And we know that SGLT2 inhibitors enhance the excretion of the glucose, sodium, and water in the urine. Okay, so it's reduce the glucose and sodium reabsorption in the proximal tubule and leading to the urinary glucose excretion, natriuresis, and osmotic uresis itself. Okay, this sometimes maybe the benefit give to the heart failure. So in addition to the double blockade that we give, so most all the patient will have the diuretics and also the MRA. So by adding on SGLT2, so it gives a small amount additional diuretics to the patient itself, and this may give the symptomatic relief and also overall outcome to the patient. And SGLT2 also gives some benefit to the maybe reduction a little bit to the hypertension, to the blood pressure, and maybe this one is for somehow give the benefit to the outcome in the heart failure where the SGLT2 been started in this patient. Okay, so several of these SGLT2 inhibitor mechanism may have beneficial effect to the heart failure, as I mentioned. It's increase the sodium excretion, and then it's reduce the preload and also afterload and reduction in the LV wall stress. Okay, and then reduction in the interstitial edema, as I mentioned, it's reduced the it gives beneficial effect in terms of the diuretics itself, and it's for somehow improve the kidney function in terms of the cardiorenal physiology in the RAAS system. Okay, so why are we doing this trial in this SGLT2 in the heart failure itself? Okay, so we know that the type 2 diabetes prevention trial is not the same as the heart failure treatment trials, and small subgroups makes for the unstable result, meaning that the result that been mentioned before, maybe it's only represent a small subgroup, and what works for the atherosclerotic CV disease may not work in the heart failure patients. As example is statin itself. And then the heart failure was not in focus of the CV outcome trial in the with the SGLT2 before. And even in the heart failure subgroup result in all CV outcome trial in the EMPA, Canvas, Declare, and WETIS are valid. We don't know for which type of the heart failure patients. So this is the summary of the SGLT2 inhibition in the heart failure itself. We can see the program in the type 2, and then which is a preclinical or subclinical stage of the disease. And then we know that there is a clinical stage of the disease, some of the trial itself, and then the detectable cardiac involvement, which is the heart failure itself. So we can see the DAPA heart HF, and what we want to focus now is the emperor reduced. So it's almost similar design. In this group, they are involved in the heart failure treatment, and we know this program before, it was the heart failure prevention program. Okay. So in the ESC 2019, the publication of the DAPA-HF, which is dapagliflozin, significantly reduce the risk of the worsening heart failure or CV death in the patient with the heart failure with reduced ejection fraction with or without diabetes. And we can see that primary outcome in this trial, there is a 26% reduction in the worsening heart failure or CV death, and 25% reduction in terms of the hospitalization of the heart failure or CV death itself. And there are 25% reduction in the total hospitalization of the heart failure and CV death event, and there is increment into the functional status by using the Kansas CT score, okay, in the heart failure itself. However, there are no specific focus into the composite kidney outcome and all-cause mortality in this trial. Even if you, but when you see into last month publication in Lancet, okay, there are by Professor Zana, he concluded that in the meta-analysis with these two trials, which is the Emperor Reduce and DAPA-HF, has shown that the composite kidney outcome is good, and all-cause mortality also is good in the SGLT2 result of the heart failure. But that was the meta-analysis. Okay, so the rate of the adverse event was similar in the DAPA group compared to the placebo. That means that the side effects of the using of the SGLT2, whether they are diabetes or not, are very similar as compared to the treatment group and the placebo group. So the Emperor Reduce trial, the objective of this trial is to assess the safety and efficacy of the EMPA versus placebo on top of the guideline-directed medical therapy in patients with heart failure with reduced ejection fraction with or without diabetes. Okay, and they randomized into the dose of the 10 milligram, and the composite primary endpoint is the time to the first event of the severe death or hospitalization of the heart failure, and the secondary outcome is the recurrence of the hospitalization of the heart failure, and also the eGFR slope. Okay, they are very detailed recruitment process, and we know that the Emperor Reduce recruited more sicker patient as compared to the DAPA group, and they are more specific in terms of the pro-BNP, and also the categorization of them with the ejection fraction. And even though we can argue the ejection fraction there is quite operator dependent, but I think they already eliminated this bias in terms of the intra-observer and inter-observer probability of the result itself. So, they also focus on the eGFR in this patient, and they also follow the patient after the medication was stopped. Okay. So as I said, the ejection fraction of the mean ejection fraction are lower in the Emperor group compared to the DAPA group, and and the result is outcome almost giving the similar outcome in these two group. And we know that the patient who are in the DAPA in the Emperor group are more sicker, and they are having more prevalence of the medication given, such as ARNI, ICD, and also the CRT. So for the primary endpoint, they are giving the almost similar result of the Emperor group compared to the DAPA as well. So the first aggregated severe death or hospitalization for the heart failure, the relative risk reduction is 25%, and absolute risk reduction is 5.2, and number to treat is 90%. Okay, so and we can see the separation even at the 90 days that this medication given benefit to the patient, whether they are diabetes or non-diabetic patient. So as I mentioned, the favors of the EMPA treatment, whether are diabetic or non-diabetic patient, so they're giving all good result in these two medication, and whether they are on ARNI or not, they're giving the good result overall. Okay, so aggregated total hospitalization for heart failure itself, first or recurrent, there are about 30% relative risk reduction as well. And we know that the change in eGFR slope from baseline, we see that they are doing a little bit worse compared to the placebo in the first few weeks. But however, the slope of the worsening is flattened, and at the end, they protect the kidney function regardless of the diabetes or non-diabetes as compared to the placebo. And even after stopping the medication, we can see the kidney function improve in the EMPA group compared to the placebo itself. So the emperor showed the benefit of the SGLT2 in patients with heart failure with reduced ejection fraction, especially the heart failure at rest at the trial is 40% or less with or without diabetes. So the primary outcome is confirmatory, and then the secondary outcome also confirmatory, and the focus on the kidney secondary endpoint also confirmatory, and is flatten the curve and is flatten the kidney function, and it gives benefit more to the patient. Okay. So the effect of the EMPA on these three endpoints were consistent among patients with the heart failure, reduced ejection fraction with or without diabetes. And the composite renal endpoint of the kidney, as mentioned, is beneficial to the patient, even though that you can see they are doing worse in the couple of weeks, but they pick up the kidney function pick up, and we know that the EMPA do give some protection into the kidney function at the end. And in this heart failure group, they are very beneficial because the effect of the blood pressure reducing as well, and also the mild diuretics effect. So they are overall improve overall function of the heart and give more benefit over time. And quality of life also increased with the EMPA group, and they feel better after 12 weeks. After 3 months, they feel better, and they stay remain better for remaining of the trial. And by directional benefits of the EMPA in the NYHA class apparent after only 4 weeks and sustained for 1 year. So they are doing more benefit, and they are worsening less in terms of the outcome, and in terms of the how the patient feel. So in the EMPEROR reduced, the safety profile was similar to the known safety profile of the EMPA itself. So there are no difference between this group in terms of the rate of the hypotension. Even we know that the DAPA SGLT2 can reduce the kidney function, the blood pressure itself, but they are not causing the hypotension effect. They are not significant in terms of the hypovolemia side effect, and in terms of the hypoglycemia, and also the ketoacidosis. And the baseline comparison with the modern heart failure trial itself in the active active trial. So the ARNI used in the Emperor is quite high compared to the DAPA itself. That means the patient is more sicker. Of course, this Paradigm HF is designed for ARNI, 100% of them into the using the ARNI. The Victoria, which is the injection of where is it worked in terms of the heart failure. But I think the pickup of the treatment a little bit difficult because the patient need to be on the infusion in the Victoria treatment group. So, however, the use of the ARNI is only 14% in this group. So we can see that in Emperor, they have the standard of care already, and the usage of the ICD and the CRT also high compared to the other group of the heart failure in the recent trial. So the primary endpoint result in the modern heart failure with the reduced ejection fraction itself, and we know that this is comparison of the table, and in the Emperor group, which is using the EMPA, as I said earlier, they're giving absolute risk reduction of 5.2, the highest in the heart failure treatment group, and the number to be treated is about 19 as compared to the DAPA group 21, and Paradigm HF group 21, and Victoria Sadinate number to be treated is 36. Okay, so we know, as I said, the SGLT2 function and the beneficial effect of the SGLT2 inhibitor may complement and improve the effect of the mainstay of the heart failure medication itself. So they have the the natriuresis. Okay, they have effect of the kidney function and also cardiorenal physiology, they have improved the preload, afterload, and LV stress, and they reduce the interstitial edema. Okay, so they are giving some benefit in all class of the pathophysiology of the heart failure, and by adding to all this may be a beneficial additional drugs. So is this drugs really designed for heart failure? Only time will tell. But the trend of the guideline now is recommending this SGLT2 to be incorporated into the treatment group. But my view is we have to go step by step, and maybe we need to start with all the standard of care, especially maybe beta blocker, the ACE, and then if they are not improving, we go into the ARNI. Okay, of course, they need to be on the diuretics itself. And then the additional, on top of that, they need the MRA in terms of the spironolactone. But I think my recommendation, if we can go a little bit more specific in terms of the newer medication, which is the Inspira, eplerenone, maybe have less side effects in the future as compared to the standard of the cheaper medication of spironolactone. So I think we can go step by step, and maybe we have to monitor the patient regularly, as we do in our center here. We have the monthly heart failure clinic just to see the heart failure, and maybe optimization of the medication and adding the SGLT2 in the heart failure patient to give all the benefit in terms of the pathophysiology of the heart failure. We can do that by a proper management of the patient in the hospital and also in the clinical setting. Okay. And as this is just to summarize what I've been mentioned before. So in terms of SGLT2, maybe give one more pillar in terms of the foundation of the therapy, especially in the reduced ejection fraction, to reduce mortality and also to reduce the heart failure hospitalization. And we know that the meta-analysis of the recent trial of DAPA and also Emperor reduced there. In terms of the all-cause mortality also is beneficial, and also the improvement of the kidney function also beneficial in terms of the heart failure and the and the kidney disease. Okay, so we know that the EMPA has all the program, and it's one of the largest trial program for SGLT2 to date, involving more than 27,000 patients, and we have to wait all this trial to give us some more data in terms of the additional to the guideline that we have. So in summary, the SGLT2 inhibitor have shown reduction in terms of the hospitalization of the heart failure in patient with type 2 diabetes, with the guideline now recommending their use in the patient with type 2 diabetes and high CV risk in the heart failure. So the mechanism by which the SGLT2 inhibitor improved outcomes for the patient with the heart failure are not well established, but as I mentioned, they may be beneficial into the hemodynamics and decongestion, and the kidney effect may play a role in this outcome. And the availability of the evidence with the two SGLT2 inhibitor in the heart failure with reduced ejection fraction with or without diabetes have shown a potential benefit. We discussed this already. And further dedicated heart failure trial with the SGLT2 inhibitor will provide more evidence to support their use in the patient with the heart failure with reduced ejection fraction or heart failure with preserved ejection fraction. So by saying that, I say thank you to all the audience for listening. We are now in the critical times. We are facing a lot of the restriction in the movement, and hopefully by doing this technology webinar, we still can keep up to date to what happening to this medical world. So thank you very much for your time to listen, and hopefully I already give some information regarding the new treatment that available and can be used into our patient, especially in the heart failure with reduced ejection fraction, whether they are having diabetes or not. Thank you very much, and back to you, the chairperson, Professor Roslinda.
Great. Thank you, Dr. Hamad, for the excellent talk and